Right. Good morning, everyone. Welcome to the second academic meeting for 2025. It's good to have everyone online. As we said, this is an online meeting only, and we're very glad to have our speaker here this morning. So I'm going to introduce Dr. Petro-Lize Wessels, who's our speaker. She is the lead consultant for patient blood management and transfusion medicine at the South African National Blood Service. She joined SANBS in 2011 after 18 years in clinical medicine and holds a BMed Sci, MBCHB, as well as a postgrad diploma in transfusion medicine, all from the University of the Free State. She is responsible for medical support to and oversight of the 7 processing labs and 85 blood banks in SANBS, so a very big job that she does, and is responsible to drive implementation of patient blood management in South Africa on behalf of SANBS. She's one of the co-authors and developers on the University of the Free State PBM short learning program for doctors, and is also an affiliated lecturer at UFS in the School of Medicine. She's contributed to 2 different textbooks, and she also serves on the AABB Standards Revision Committee, as well as the Global Transfusion Forum's Practice and Policies Implementation Working Group. She is an excellent speaker. I've had the pleasure of knowing her for a few years, and we've worked on a few guidelines together. And I'm going to actually just hand over now and stop talking and let Petro-Lize to do what she does best and just teach us a little bit more about patient blood management.
Thank you so much. And thank you so much for the invitation. I was just telling Jarrod earlier, I really miss interacting with the doctors since they put me into a chair in the glass palace here in Roodepoort. So let's start with why would a GP that joins SANBS all of a sudden, when her day job is looking after blood banks and PBM, start talking about ethical and legal considerations. Way back when I joined SANBS, one of the things I told the medical director of the time when he interviewed me for the post was that my transfusion knowledge is severely lacking because there are just so many questions that nobody could ever answer for me. And he countered that with a question, how would I then go about training doctors and nurses if I don't have the knowledge? And my answer was, I would go out and start reading and find the answers to all my questions. And as I started reading after I got the job, and that was a big mistake, very bad for my sleeping patterns and my health, I stumbled on all these ethical and legal stuff in the background. And I realized that nobody tells that to us. We are out there practicing, we are truly trying to do the right thing, but without this background knowledge, we can end up in trouble quite easily. And that's how I got interested in this particular topic. And as PBM grew, I realized more and more that PBM ethics and the legal stuff is just so entwined that you really can't have one talk without the other. So, for those of you who leave early because it's Friday morning, we need to get those wards empty for the weekend. There's the summary, just to help you a little bit before you decide if you want to leave or stay. That little pitchfork diaper-wearing devil, it's a very sharp pitchfork, ladies and gents, it's the law. And then our fairy godmother is always patient blood management. And if we can put all of those things into perspective and into our thinking, I can promise you we will have the optimum patient outcomes that we can get. So a couple of things has changed since I graduated 32 years ago. And the thing is that ethics now is about making the right choices, considering all your circumstances. And if you want to consider all your circumstances, you must have knowledge of the circumstances of the time. And keeping your knowledge up to date is very important. It's also important that we realize as practicing doctors that transfusion is not an isolated thing anymore. It's not just about the blood product that goes into the patient or doesn't go into the patient. And as transfusing and prescribing doctors, our eyes must be open wider because our duty is much bigger than just the patient sitting in front of us. So everything we do, the way we think about treatment, all of that should be linked to the broader public's best interest and working towards achieving the full health potential of every patient. And that's a concept called health equity. So PBM principles are not new. I think they have been published for the past 45 years, of obviously being shot down when the poor people started, but now widely accepted. And therefore we can't say, I did not know anymore. So you must make sure that you at least understand the basic principles of patient blood management and include them in everything you do. A lot of the headaches are ours. I'm just going to focus on the headaches for the prescribing doctor, the transfusing doctor, or the transfusing registered nursing practitioner. Let's start with ethics. That's always the more easier to digest. And Korsky said ethics is the branch of knowledge that deals with moral principles. So gone are the days when the only thing we as doctors had to do was just, oh, this is the most appropriate treatment. That is what we're going to do for the patient. We also have the broader ethical obligation to benefit the patient, avoid or minimize harm, and always respect the values and the preferences of our patient. So the 4 principles of bioethics is not new. It's been around since before many of us graduated, and you all know them. The thing that we often do not talk about is the situations where the one is in conflict with the other. And that is where you phone a friend. And if there are young colleagues on the line, phone a friend with grey hair, because I promise you we've earned our grey hairs through the years. And you discuss this case, and you document your discussion. And what this discussion tells you should take preference, that is the route that you go. But whatever you do, if you transfuse, if you don't transfuse, what you transfuse, when you transfuse, how much you transfuse, all of those discussions should be based on the 4 ethical principles. So when we look at autonomy, in transfusion medicine, it's still the same. A competent, rational individual have the right to make an informed, uncoerced decision of what will or what will not be done to their bodies. So in transfusion, that means informed consent and informed refusal. So the requirements for informed consent, if you go and read the HPCSA booklet, is that the individual must be competent to understand, and they must be able to comprehend what we disclose to them. So we can't use this high-level, convoluted medical terminology. They will not understand or comprehend what we're trying to impart on them. So watch the language that we use, bring it down to a level that the patient can actually understand. The patient must receive full disclosure, and the information that we give the patient must enable the patient to make an informed decision. So we can't coerce the patient by omitting certain information or focusing on information that we would like them to rather hear. Obviously, then there is consent to the proposed intervention, and this must be documented in writing. Informed refusal, let's start with the fact that we always have to respect the values and beliefs when a patient says no, thank you. And again, the whole process must be followed, and it must still be documented. But here's the thing that I learned from working in SANBS and spending time in hospitals, and the doctors and the nurses taught me this thing, and I never realized it was so actively out there, but I encounter it across 8 provinces. Quite often when I give this talk in person, afterwards a doctor or a nurse would come to me and say, you know what we see? During the daytime, when we do morning rounds, the patient says, no, I don't want a transfusion. However, at night time or after 6 o'clock or whatever, I get called back to the ward and the patient says, can you do my transfusion before the family comes back tomorrow morning? And that made me realize that coercion is not just from us as the doctors without wanting to coerce, but inadvertently sometimes coerce, to take a transfusion. But it can also be a social coercion from their family or friends to say no to a transfusion. And therefore we must make sure that we ensure full confidentiality for our patients. Otherwise we can't say it's an uncoerced decision. And please remember that previously autonomous persons that are presently incompetent, we have to respect their previous preferences and choices. Let's talk about beneficence. That's our duty to act to benefit of the patient, promote patient welfare, and very important is to understand that beneficent actions can help to prevent harm and remove conditions that may cause harm. And I was very guilty about this when I was a young, let me call myself a foolish doctor. You would do your ward rounds and you would see that brown paper bags, and let's just be honest, you know, when I started working, all these nice little BRB hampers didn't exist. All blood came in brown paper bags. and you would see this brown paper bag sitting at the nursing station or at the bed, on the bedside table of a patient as you walk through the ward. But it wasn't your patient, so you didn't stop to ask the right questions. And ethically, our obligation would be to stop and say, what's in the bag? Is it blood? Shouldn't it be cold chain? How long has it been standing there? Because we have to remove any condition that may cause harm to any patient, not just our patient. So in transfusion, first and foremost, a transfusion must be based on a genuine clinical need. I mean, that's a given. If any post-transfusion information becomes available of possible, potential, or probable harm, we must inform the patient. And that is something we call the look-back program. Now, in the public sector, there is a delegated person in each hospital that receives this look-back communication from SANBS, and then the patients must be traced and tested and see if there was a transfusion-transmitted infection, and the process must be followed. In the private sector, this letter will go to the individual doctor, and we can't file it in file 13. We've got the ethical obligation to act on that look-back communication from the blood service. So any information concerning the transfusion obviously must remain confidential, and you're not allowed to limit your patient's options because your knowledge is outdated. I'm not saying become a PBM specialist, but you have to know the basic considerations, the basic thinking behind PBM. Non-maleficents speak to the fact that we should do no unnecessary or unreasonable harm, and we should not expose patients to unnecessary risk. On the other hand, currently we are in utopia since middle November. This country has never seen such consistently high blood stocks. I want to kiss the feet of our donors because SANBS can sleep at night at least. But we often go into stages where you get that dreaded cutback letter, where we tell you we're at 2.5 days stock. If you order 3, we might only have 1 in the fridge for you. So when we hit to 2.5 days, the reality behind the scenes is that the rural areas can't get their hands on blood as fast as you guys in the urban areas can. And because we don't have a lot of blood to ship at a given time, the blood bank fridge might run empty before the next courier drop-off actually takes place. So therefore, we need to be mindful to preserve the scarce resources at all costs anywhere in the country, because we cannot deprive others from goods of life. So we're back to the fact that in transfusion, this means genuine clinical need, benefits versus risk, and the best course for the action. And then keep in mind that your risk of transfusion is not related to the transfusion event, but the risk is related to each and every product that you transfuse. So you can't be transfusing unnecessary products. If you have inadequate knowledge of the treatment, you might be using a normal red cell where a filtered red cell is indicated. You might be not asking for an irradiated product and trigger severe adverse events in your patient. So inadequate knowledge is also considered unethical. And then the standard of care, like I've said, that brown paper bag sitting on the table, or I'm in theater and I don't have a blood warmer and I'm running the tubing through a bucket of warm water. I've got no idea what the flow rate is. I've got no idea how warm the water is. All of that speaks to standard of care. Very importantly, you cannot use uncross-matched emergency fridge blood just because the driver doesn't want to drive to the blood bank. So many of the big hospitals in Joburg area is very fortunate they've got a blood bank on site. So SANBS supports about 553 was the last count, transfusing facilities across 8 provinces. Yet we only have 85 blood banks. So you can do the math and realize how many hospitals don't have access to a blood bank on site. And the temptation to just use uncross-matched blood is very high sometimes, but you're not allowed to. You have to only reserve it for emergency situations. And then the other thing that we unfortunately see quite often is that an elective case comes in, admitted for surgery tomorrow. Oh, the patient is anemic. You know, the anesthetist is going to cancel my patient tomorrow morning, and I can't go through all of this because the patient has been waiting for months. And what do? I transfuse the patient to treat a normal pre-op anemia. That is also not an ethical way to do things. So let's talk about justice. It's about the equitable distribution of benefits and burdens. So when we have enough blood, everybody is smiling. When the stocks fall, everybody must share the burden, and we're going to do cutbacks across the country for everybody. Fair, equitable, and appropriate treatment of all patients, that is a given. So in transfusions, what SANBS is striving to achieve is that at least whether you are giving birth in Lusikisiki, my apologies, or whether you're giving birth in Garden City in Joburg, you must at least have access to red cells and some form of a clotting factor, whether it might be FFP or whether it might be freeze-dried plasma, whatever the case. Medical decisions relating to transfusion should be based on the best available evidence, obviously adapted to your circumstances. If you're sitting in a tiny little hospital like Tshwaragano in the Northern Cape, which I still don't know how those doctors cope because they've got nothing to work with, and you don't have a cell saver, who can fault you for not having a cell saver discussion with your patient? You don't have it available. Your local circumstances don't give you access to it. You can't be faulted for it. Patients should receive the most appropriate blood products available and only the products that are clinically appropriate and will actually contribute to the optimal outcome and patient safety. Keeping in mind that wasting of a scarce resource may impact on the greater patient population. So distributive justice speaks to the fair, equitable, and appropriate distribution of scarce resources, and it also speaks about the care of uninsured patients. So I love numbers. Numbers tell a story, but numbers can be very dangerous. Because if you just look at the numbers without understanding the background to the numbers, you can jump to very wrong conclusions. So I'm going to show you one publication. And you might make one conclusion, but actually it means something completely different. So this is a publication that was done for 2014 to 2019 red cell usage. And I've seen the graphs for more recent stats, and it looks basically the same. Not much has changed. Ne? On the left-hand side in the dark blue, you have the public sector. On the right-hand side in the light blue, you've got the private sector. Now, on the right-hand side of every graph is the female population. So if you look at the female population in the public sector, it kind of looks like the side view of a pregnant patient, and that is exactly where the red cells in South Africa is going to. Females of childbearing age that does not have access to private medical care. If you look at the private sector, you don't see the baby bump. You see basically a flat line. What should that make us ask? Why are the females in the public sector, which don't have access to private medical care, needing so much more red cells? Is it because they can't access medical care? Is it because they never get to a facility where a doctor, because the doctor must prescribe the blood. If there's no doctor, the blood is not prescribed, ne? Can't they access the doctor? Is it that the basic antenatal program out there is failing? They don't have access to basic ferrous sulfate and folic acid? Is it because they never screened for anemia to start off with? What is the reason that our female population that is uninsured needs so much red cells? And that is a question and a concern for all of us. And those of you working in the public sector should be hammering those questions and be asking those questions if you see your antenatal patients or your females of childbearing age coming in with untreated, undiagnosed anemias. Same publication. I want to draw your attention to the two columns on the far right. Far right is the per capita use in the private sector, 34, 36, 37, 38, 36. Right next to it is the per capita use in the public sector, 11, 12, but mostly 11. Does that mean that our colleagues in the private sector is wasting blood? Because that's the immediate conclusion many people would make and say, yeah, it's those private doctors, they just order and waste. Guys, I just did the stats for our mid-year collections target review on Monday, and I presented it on Tuesday. The average HB trigger for the private sector in South Africa is 8.16. How can we say they're wasting blood if the average HB trigger is below 8.5? They're not wasting blood. Insured patients in South Africa has got access, easier access to medical care, easier access to a doctor, because you need a doctor to prescribe the blood, ne? And obviously, the higher level or the more complex level of care, the wider spectrum of care that you have access to, a lot of that care goes hand in hand with higher blood product use. So again, this should trigger you to ask, why this discrepancy? What is happening to our public sector patients? Some more numbers. You will see the average units per patient in the public sector 2.29, private 4.02, and 4.03, sorry, it's 8.18, not 8.16, as I said, my mistake. So really, this is not over-transfusing on the side of the private sector. If you look at the plasma products, now you must remember why patients need plasma. Obviously for clotting factors, but also very importantly for therapeutic plasma exchanges. So if you are in a setting where therapeutic plasma exchanges are more widely used, more widely available, we use per procedure anything between 11 and 15 units of FFP for several days on end. So again, if you understand the background, you will understand why the private sector's plasma use, it almost doubles. And the same goes for platelets. So if you think about, and I'm very happy to report that the stem cell transplant in many public hospitals has really picked up, and the range of care for our patients that are uninsured, it's picked, well, since 2011 when I joined, it's just a different scenario. And yes, we're not there yet. It should probably be more widely available, but the growth in that area in South Africa is very heartwarming. But just one example of a type of patient that would drive the discrepancy in the private and public sector pooled platelet usage. Now we get to the little devil. You're all relaxed. You've had your coffee. I can give you some bad news now. And we start with Chapter 2 of the National Health Act. And this speaks about informed consent, not just for transfusion, informed consent in general. The first important thing is the user, which is the patient, must receive full information because they need to have full knowledge. And the healthcare provider, we as the doctor, who makes the decision to subject the patient to this form of treatment, has the duty to inform the patient. You need the consent of the patient after you have given them full information, and you must allow them time to participate in this decision-making process. There are conditions when we can intervene without consent. We'll get to that. And then Section 13 is still a big concern for me in South Africa. That's our obligation to keep record. Now that irritating little form that just crept up on the corner of the screen that I know all of you hate because you say it's too much for writing for you, that is not only a legal document, it's also considered a clinical record. And if I look at the way that these forms reach us, the way that these clinical records are sent to us to order human tissue to put into your patient, then I have to ask, what is the condition of the rest of our clinical records? And I really hope that the request form quality of information that we receive in SANBS is not indicative of the quality of all records that we keep, because then we are in trouble. So about informed consent, Chapter 2 is very specific. It must be done by the treating doctor for a specified service in a language that the patient understands, at a level of understanding. We're back to that ethical principle of the patient must be able to comprehend what you tell them. Ne? It must be obviously written. There must be a witness to consent. Keep in mind that the witness is not responsible to witness the content of the discussion. The responsibility of the content of the discussion sits on the shoulder of the doctor. The witness is there to say that the process took place, it was an uncoerced process, the patient had time to participate in the decision and ask questions, and the patient was given enough information and questions were answered. That is the responsibility of the witness. If you have refusal of treatment, obviously the same process must be followed. It must still be documented. So what are you supposed legally to tell your patient? What are you going to do? What are the benefits? What are the risks? And I have found over the past 14 years that doctors, just like I did before I joined SANBS, severely underestimate the risks related to transfusion. And if I don't know about the risks, I won't be able to tell my patients about the risks. So I have the duty to keep my knowledge up to date. You have to tell them about the available alternatives, the likelihood of success, the number of interventions planned. Very important if you think about babies with non-lodging mothers. How are you going to consent every time if the baby is in Kimberley Hospital, the mother stays in Kuruman? It's almost 300 k's away with very little transport between the 2 points. If you think about your ICU patient, are you going to get consent, bring the family back and daily and sit and have an informed consent discussion with them? So for every hospital, I would suggest that you go to the hospital management and management make a decision that they are comfortable with for how long consent can be valid for. But the number of interventions planned must be discussed with the patient or the mother or whoever is giving consent. The recuperation time and the costs. So medical aids are becoming more and more iffy for paying for transfusion and courier trips, etc., etc. So you must have the cost discussion with your patient in the private sector. In the public sector, I urge you to please have the cost discussion with yourself internally, because remember, this is the size of the cake. And the more of the cake we take for transfusion-related costs, the less of the cake will be left for other essential health services. So we have an obligation to always have that discussion with ourselves. So when are you allowed to administer treatment without the patient's consent? When I, as the patient, mandate somebody to consent on my behalf. You can go to the spouse, the partner, the parent, the grandparent, adult child, brother, sister. So currently there's an order in the law books, and we all know that we sometimes work with groups and cultures that got a very hierarchical system in the family. And the hierarchical system, the social hierarchical system in that family might not be the same hierarchy as this order. So it can easily make for difficult discussions. Be careful when you enter in those discussions and try to incorporate and include and acknowledge all of those factors. Treatment can be authorized in terms of law or by a court order, and if failure to treat poses a serious risk to public health, you can intervene without consent. If delay in treatment might result in death or irreversible damage, but, and this is a big but, the user has not expressed, implied, or by conduct refused that service in the past. So let's take the most common one, a Jehovah's Witness patient. You can see the directive of life, even though it's a polytrauma patient and the patient may die without a blood transfusion or a red cell transfusion. Please keep in mind that you cannot say, oh, but it's a life-threatening emergency. You've got proof of the decision that this patient made when he or she was a mentally competent adult, and we cannot override that decision. So Chapter 8 in Regulation 179 speaks specifically to the transfusion of blood and blood products. So we'll break this long sentence down into two sections. So originally in 1965, Section 59 read, only a registered medical practitioner or dentist, which always worried me, the dentist part, or a person acting under the supervision or instruction may administer blood. Let's stop the sentence there. So in South Africa, there is no way that we will ever have the luxury of a doctor standing next to the bed and watching the transfusion take place. We don't even have enough doctors to treat all the emergencies that come in. So supervision is not going to happen. So legally what they require is an instruction to administer blood. So you need to prescribe the transfusion, because right when I joined SANBS in 2011, one of the meeting groups that I joined was when there was a walkout of nurses in KZN because they said it's not within their scope of practice to administer blood. And SANK was very clear. It is within their scope of practice if a written instruction is given, the prescription, if there is a procedure to guide them on how to do it, your hospital policy, and if they have been trained on how to do it, so training on the hospital policy. So if all of that is in place, you prescribe, and it's well within the scope of any nursing practitioner to administer blood. And no, the doctor does not need to start the first unit, because the same risk of transfusion reactions is linked to unit number 1 or unit number 10. So there is no reason why the doctor should start the first unit. Let's go to the second part of the sentence, or prescribe blood or blood products. So obviously something went wrong, to the extent that in March 2012, Regulation 179 was promulgated that said no blood or blood product may be ordered unless it's prescribed by a medical practitioner in writing on a form created by the Blood Transfusion Service. So also hemovigilance is discussed in Regulation 179. And just like we have an ethical obligation to participate in surveillance programs, we have a legal obligation to participate in surveillance programs. So that means all adverse events. You cannot say, I'm not going to fill this hated transfusion reaction form and take samples and send it to the blood bank. I know it's an allergic reaction. You are legally obliged to report all transfusion reactions to us, and you are legally obliged to act on all look-back notifications that you may receive. So this is the hated form that all of you always ask us, please just make it shorter. And I'm going to try and explain to you why we can't make this form shorter. So there we get the patient information. So it's a legal requirement that all blood must be traceable, cradle to grave or vein to vein. So we need to know who received blood. But there's also a safety aspect to this. So today, you take a sample from me, it goes to the blood bank types me as an A positive, and I get my A positive cross-matched blood. All is hunky-dory. Sunday night, 3 o'clock, I need blood again, and everything is rushed, and you spell my name differently, you spell my surname differently, you write down the wrong date of birth, and when they look me up on the Meditech system, then obviously I don't exist yet. I don't have a file yet, because the patient identifiers are now different. They open up a new file. Meanwhile, back at the ranch, because in the chaos of Sunday night, 3 o'clock, somebody did a sample switch and another patient's sample went to the blood bank with my name on it. The blood bank now does the cross-match. I see, oh, this is a B positive. Hunky-dory, and they sent out 3 units of B positive blood to me, who is in fact an A positive. Had you put the unique identifiers of the patient in correctly, and the same every single time you send a request form, on the blood system, we would have seen, oh no, but Petro-Lize already have a file. What's going on here? On Friday, she was an A positive. Now on Sunday, she's a B positive. Quickly pick up the phone the ward and say, guys, I think there's a sample switch because the blood group has changed. Send me another sample. And you're actually protecting your patient from harm that way. This is where you choose the products. And my question to you is, do you know which products patients needs filtered products versus just normal red cells or normal platelets? Do you know which patient can do with a pooled platelet? You don't have to incur the extra cost of a single donor apheresis platelet. Hopefully, by mid-year, we will have filtered pooled platelets rolled out much wider than the areas where we have started. And you can actually consider a filtered pooled platelet for like 80% of the patients that are currently consuming single donor apheresis platelets in South Africa. Again, a significant cost saving for the healthcare system. Very, very important is your type of cross-match. Do you understand the difference in risk to the patient between a standard cross-match, which is a full cross-match, an emergency cross-match, because I think it's only going to take 30 minutes and the patient must go to theatre and the form never got to the blood bank last night. Let me tick an emergency cross-match. That's a partial cross-match. It's only a room temperature cross-match. That sample has not been incubated. We don't know anything of the warm-acting antibodies in your patient and how it will react to the unit we plan to give the patient. So in other words, your patient is not at 20 degrees, I would sincerely hope. Your patient is at 37 degrees, yet you haven't chosen the option that tests for irregular antibodies at 37 degrees. Emergency cross-matches are not there to speed up things or to correct mistakes or forgotten forms. It is there truly for emergency situations. And then obviously the uncross-match comes with a higher level of risk to the patient. The diagnosis, D64.9, anemia, one word. About 80% of the request forms we receive in SANBS across the 8 provinces still don't have a ICD-10 code allocated to it. And then the next most popular one is anemia unspecified, and that is D64.9. And then you would get the stalwarts that would tell us PPH, GIT bleed, and I'm so thankful they keep me sitting in my chair, not running for the hills. But guys, we need to give proper diagnosis, and we need to start using ICD-10 codes. So this is where the doctor signs, and this is also where the doctor must put in their contact number. Please don't give me a short dialing code. Please don't give me the ward number. I need your number as the treating doctor. And the reason for this is about 2 calls back, I struggled for 9 hours to get hold of a doctor because we detected irregular antibodies in the patient's sample. It was a short dialing code that nobody picked up. We finally sent somebody to the ward, and the ward sister refused to give us the doctor's direct number. There was nothing I can do because I cannot tell the blood bank, release a blood product when we have detected irregular antibodies in your patient. There was 9 hours before that doctor actually ended up phoning me and asking me, where's the blood for my patient? And I said, gee, still with me because I couldn't get hold of you. Now, if the patient suffered any negative consequences in that 9 hours, it would not have been SANBS that's responsible. It would have been the doctor who requested the blood without giving us a way to communicate with him or her if we pick up anything weird and wonderful. You also sign your name in that area of the form, and you sign your name directly on top of this block there. I love giving this talk in person because I ask the question, how many of you have ordered blood in the past 2 months? And many hands go up. Then I ask, how many of you have filled this form in the past, has read this block in the past 2 years? And then all the hands drop. And I don't know how much more visible SANBS must make this. It's warning, you can't miss it. It's pink. It's big fat red letters, and yet the doctors don't realize that they're signing this document without reading what they're signing. Every time you order blood, you are signing to a couple of things. You are signing to the fact that blood may transmit diseases, that you know how we collect blood, who we collect it from, what we test for, how we test it. You also sign to the fact that you acknowledge that this is a country with a high disease prevalence, and therefore your risk of window period donations is there, and although the tests are negative on the donation testing side of SANBS, that unit can still transmit infection. It also said you took this into account, you discussed it with your patient, and you got consent from your patient. And then you also sign to the fact that you say this exposure to the patient, exposure of the patient to this risk is medically justifiable, and you have considered alternatives. Now, if that isn't bad enough, this is the emergency fridge form. So remember, emergency fridge blood is sealed into an emergency fridge without us knowing who's going to receive the unit. So it's a blank form. But remember that cradle to grave matter. We need, or vein to vein, we need to know who received this unit. So first of all, uncross-matched blood, only for life-threatening emergencies. My question to all of you is, do you know how this blood product reaches your hospital? Do you know how it's transported to your hospital? Do you know if the temperature is taken before it's put into the emergency fridge? Do you know what the temperature was when this blood reached your hospital? Do you know if the blood in your emergency fridge is cable tied? Not with hospital cable ties, because I can cut them, remove the unit for who knows how long, and just use my own cable tie and cable tie it back in. But cable tied by a SANBS provided cable ties. One cable tie per unit, because you will immediately know if that unit is lying on the floor or on the rack and not hanging, that this unit was removed at some stage, and it must trigger alarms with you. You must go to your hospital policy and you must read how the maintenance and the management of the emergency fridge in your hospital works, because you as the treating doctor makes a decision to expose the patient to the risk of this product. Obviously, traceability, we need the patient information. And then a lot of the hospitals tended to say, my staff can't do RH test kits. It's just too much hassle. I just want O-neg for my fridge. That is nonsense. We've stopped that. O-neg is extremely scarce, and one hospital doesn't have the right to hoard O-negs because it's convenient for them. Every single emergency fridge will carry O-pos and O-neg, and you will have to do the RH test on your patient to prove that you are actually using the O-neg blood for the appropriate patient group. Diagnosis, what you write there, does it indicate the life-threatening situation that you're dealing with? If not, you should be worried. And then the signature. And I was one of these doctors, very, very foolishly. You walk in the morning to start your casualty shift, and the nurse comes running and say, oh, doctor, last night was absolute chaos, and the doctor left and they didn't sign the form, and the driver needs to leave to get the blood from the blood bank, and you know, when the driver leaves, we don't have another trip for the rest of the day. I only worked rural my whole career, I must say that. And then what I do, I sign the form because, you know, the poor patients, this fridge can't be empty. My question is, how often do you look for patient files and you can't find the file when you know the patient is known to you? Very often, ne? So if the patient files goes missing, 5 years down the line, there's a case where the patient says, I was exposed to a transfusion, it caused X, Y, or Z, and now they ask for SANBS, and SANBS says, oh, it was an emergency fridge unit, and you were the doctor who signed this form, while the diagnosis could not have been properly documented. You don't know what the cold chain management of the fridge was, and your name is on this form. Please do not sign forms on behalf of other people. I call us the marshmallows, because we are too soft and we do stupid things sometimes. So litigation is a reality in South Africa. I typed in the words on Google and a very helpful website popped up. Now, this website is available to the public, and it's very clear that medical malpractice includes faulty blood transfusions. The website also tells the public that you have the right to access your medical records and charts because it can help you build a case. Furthermore, it tells you what is considered medical malpractice. When the doctor failed to obtain informed consent, when the doctor didn't adequately explain the risks involved, when there was an administrative error or improper testing led to the wrong blood type being transfused, when a transfusion wasn't necessary, if a group of your peers deemed the transfusion to be clinically inappropriate, that equates to medical malpractice. A blood transfusion was administered improperly, and infected blood was transfused due to improper screening. That sits solely on our shoulders in the blood service. The website also tells you who you can take action against. The doctor who performed or ordered the blood, the hospital where the infusion was done, or the donation service that supplied the blood. So this is a reality that we live in, colleagues. Delictual liability means harm or damage was caused either through negligence or intentionally, and a reasonable person would have foreseen harm and avoid the harm, but we as the defendant failed to take the steps, and then like I've said before, our actions will be measured against a group of our peers. Now, if you followed an acknowledged guideline, evidence-based, up to date in your decision making, you can't be faulted. you have got, say, I followed this guideline in my decision-making process. If we at SANBS remain SANBS accredited, we keep all the records of competency, our calibrations, our validations of our equipment, etc., we can't be faulted. So stick to the rules. Criminal liability is assault or culpable homicide. So assault is clear, administration of a transfusion without consent. Culpable homicide is when you wrongfully or negligently cause the death of another person, and it can either be by the blood service or by a practitioner, and then whoever is involved in any step of the chain of transfusion, I beg you to please be aware of your legal responsibilities. Just on a side note, there were 2 convictions of culpable homicide related to transfusion in South Africa, one a doctor and one a lab technician. Different cases, not the same case. So I've given you a lot of headaches. I can't send you to the weekend without some solutions. And I've grouped them together. So the first group is easy. Transfuse blood when it's clinically indicated. Warn patients of the risks and inform them of available alternatives, and do the consent process properly. That sits on our shoulders. We are there next to the bed. This is 100% within our control. The next group, a little bit difficult because we're not in the ward 24/7. Correctly identify the patient and the number of units to be transfused. Appropriate compatibility tests have been performed. Ensure that the blood has been handled correctly prior to and during transfusion. Blood has not expired, and only responsible persons are administering the blood. You're not there. How do you make sure this happens appropriately or safely in your hospital? Monday morning, you ask for the hospital transfusion policy and you start reading it. But you start reading it from different eyes. All of these aspects must be covered and clear in that policy. Otherwise, there's gaps in the policy. Blood must be administered at a proper rate. It's easy. Just prescribe it like that. Next group, also a bit difficult because you're not there. Observe and monitor the patient before, during, and after the transfusion. Manage any untoward reaction. Now, you can only manage the reaction as a doctor if the nursing staff recognizes the reaction happening in the ward. So does the policy and does the training of the nursing staff in your hospital adequately prepare them to recognize reactions and effectively and timely inform you of them? Retain blood samples as required and report reactions and death. And then lastly, well within your control, trace, counsel, and test recipients that are identified through the Look Back program. If you can tick all those boxes, you will sleep easy at night, but most importantly, your patient will have the best possible outcomes and best possible safety related to transfusions. So to summarize, please empower your patient with adequate and appropriate information and allow them to participate in the discussion. Always think of the 4 principles of ethics. Don't limit your patient's options because your knowledge is outdated. Know your legal responsibilities and obligations. And then lastly, don't forget about the fairy godmother. Always think PBM and always screen for and treat anemia. Thanks very much. I'm happy to take any questions.